All right, so my name is Chris. So let me start off. This is actually going to piggyback off of Ankita's lecture, basically discussing more so like specific ocular trauma. So a lot of times we have individuals that come into Jacoby. They tend to look like this, and one thing that we tend to forget about is orbital compartment syndrome. Just to give a quick kind of view, so you're going to have your bony orbit, and within that bony orbit, you're actually they usually develop sometimes a retrobulbar hemorrhage. And so it's between the orbit, it's in between the orbit as well as the bony structure. And a lot of times it's usually due to mostly trauma. It could be a fall, somebody hit with a baseball bat, a golf club, whatever it may be. And then other times it can be due to eye surgery. It can also be due to spontaneous bleeding, and that could be either if they're on any type of blood thinners or if they have something wrong with their platelets. It can be due to orbital cellulitis, abscess, or tumors. Oops, sorry. So a lot of times these individuals will come in with decreased vision. They'll complain of seeing double. They'll endorse that they're having eye pain or periorbital swelling. On our findings, what we'll tend to find is that they have proptosis. They'll have a diffuse subconjunctival hemorrhage. Usually, if you're using the tonal pen, if we can find it at Jacoby, then they'll have increased intraorbital pressure, limited extraocular motility, and afferent pupillary defect. So just to kind of give everybody a heads up of what an afferent pupillary defect is, let's say, for instance, that you have a defect in your left eye. If you had a light and you were using it as a pendulum, and if you shone that light in your right eye, they both will constrict. But if if you shine in the left eye, they'll actually both remain dilated. And so basically the left side is what's affected. And this is usually common in orbital compartment syndrome. What we need to be aware of is that when we're concerned for this, or more so like these emergent ocular injuries, you have 90 to 120 minutes to react and actually, whether it's a procedure or you need to call ophthalmologist, whatever it may be. The procedure that should be done is actually a lateral canthotomy and an inferior cantholysis. Absolute indications are usually proptosis, intraocular pressure greater than 40, and if the individual has loss of vision. For the contraindications, it's going to be a global rupture. So for these, a lot of times the only thing that you really can use is lido and epi because you want to react as quick as possible. Positioning is probably the most vital thing. So you want to make sure that the bed is roughly about 10 to 20 degrees elevated, the head of the bed. And then you probably want somebody to hold the head because they will still feel some pressure, even if you apply the lido and epi due to like the ischemia and the acidosis which is present. Sedation, you always can't do it because you're kind of, you're pending for time, so you can't. There's still like this whole question if you should use ketamine or not. Some still say that it can cause increased intraocular pressure, but they've actually done like studies in peds, and it was like a small study, but it showed that there is no variability in the intraocular pressure. So I'm gonna show a quick video in regards to how the procedure should be done. But if you actually look, you'll see actually where you're cutting. Oh, I don't have the. Let's see. Can I use this? No, I can't. So the canthal tendon that's actually where you're going to be cutting. The issue is that there's an inferior and a superior portion. Usually you want to aim for the inferior portion, and then you'll attempt to actually aim at the superior portion. The only problem is when you tend to go more superior, you can damage your aponeurosis, or there's sometimes where if you're aiming more superior, you can cause damage to like the lacrimal artery and the nerve, which are still on the other side, but if your scissors are too long. So, let's see. Hey Brian, how to display? Oh, here you go. Forget it. Yeah.
And real footage of a lateral canthotomy. That's a procedure to release an orbital compartment syndrome. So if you have a bunch of pressure pushing on the eye, usually that's from a retrobulbar hematoma. That's a pocket of blood pushing the eye forward. We want to create an incision so we can basically let the eyeball come forward. You're only going to remember one number. I want you to remember 40. 40, that's 40. It's the intraocular pressure when you need to cut and release the compartment syndrome. Let's go through the steps of the procedure. First step is you want to get it numbed up, so lidocaine with epi, be a nice doctor. Second, you're going to crush the lateral canthus with a clamp. This devascularizes the area. Now, here it is in the real procedure. You want to leave that clamp there for about 1 minute so it doesn't bleed like stink when you cut. That's coming up. Step 3. Cut the lateral canthus. You're going to cut towards the orbital rim on the side. Next, you're going to cut that lateral canthal ligament, which has both a superior and inferior cruce. Sort of looks like a wishbone on its side. You want to cut that inferior cruce first. Sometimes this releases enough pressure on its own, but if not, cut the superior cruce. Now it can be real hard to see, even for you, not just the patient. There's a lot of blood, oozy stuff, so get in there with one of your instruments, get some tactile feedback. It sort of feels like a guitar string. At the end, recheck your intraocular pressure to...
All right. So you know you've actually you had success if the patient complains that, well, the patient endorses that they have better visual acuity, if the afferent pupillary defect has resolved, or if they have a decrease in intraocular pressure less than 40. After this procedure, you need to make sure that you continue to have the head of the bed elevated. You want to manage the intraocular pressure, whether it's with IV medications or PO. Additionally, just control pain, reverse any coagulopathies, and avoid anything which can increase your intraocular pressure. There are some complications that you can have. So you can have a lower eyelid drooping and ectropion, which is basically where the lower eyelid actually is pushed outwards. This can actually only be treated, they have to actually go back to surgery in order to resolve that complication. If you damage the aponeurosis, the levator aponeurosis, you can have ptosis of the eye as well. And then, of course, infection and fibrosis, what they can have. If they develop fibrosis from the procedure, then they have difficulty with their ocular movement. So just take-home points. Consider ocular compartment syndrome and ocular trauma. The time you want to manage within is between 90 to 120 minutes. Remember that basically for your absolute indications, it's going to be increase in intraocular pressure. Of course, if the patient's endorsing that they're having any significant change in their visual acuity, you want to verify that as well. And the procedure is a lateral canthotomy and an inferior canthololysis. And that's it.